Okay, let's look. So early detection saves lives. It's just plain and simple. Let's look at the number 2 killer, colorectal cancer. So the standard of care is to do what? Starting age what? Age when? Yeah, so that changed last year. It used to be 50. It changed to 45 last year based on population studies that went from 90s to early 2000s. So the study actually ended in like 2004. And what was being shown is that men primarily, but also some women, age 40 to 50, had a 20-fold increase in right-sided colorectal cancer. 20-fold. But it took another 10 plus years for the guidelines to change. And the screening is at age 45, not 40. Because if we start doing it at 40, it's going to cause too much disruption to be doing that. So what should you do? And you should really be thinking, in addition to colonoscopies, risk stratifying, and that's by looking at stool DNA, looking at microbiome, and looking at capsule endoscopy. And I'm going to talk about capsule on the next slide. So it's based on the concept that if you have a cancer here, again, it's not just sitting there. It doesn't just sit there and look pretty. It's shedding its DNA and its material, and you're literally pooping it out. You know, you're pooping it out with debris, and we can pick it up with very high accuracy. By high accuracy, I mean like over 90%, that there is high-grade tumor-based content in the stool. And when combined with genetic risk and microbiome risk, we can get a very good gauge for what is this person's risk? Is their average risk % lifetime risk for colon cancer the same way as 15%? You need to be way more vigilant. So a huge part of the assessment is what's called a microbiome. A microbiome is the composition of the gut. What bacteria reside in the gut? What % of immune system resides in the gut? Ed, don't say it. Yeah, about 70%, right? So this is like this is our skin and gut are the biggest barriers. And what we know is that the more diverse your gut flora is, the more rich your microbiome, the healthier your immune system, and the better you're able to fight off cancer and other autoimmune conditions. So much so that people with metastatic and early stage colorectal cancers, melanomas, are getting fecal implants to actually boost the immune system. And we know that we can treat folks with certain immune therapies to turn the immune system into Superman. And if we actually tickle their gut flora and the immune system into fighting and recognizing the foreign entities, they have drastically different outcomes. What I mean by drastically, they live 2, 3, 4 times longer than average. And the thought is, well, can we bring this earlier? And this is based on population studies, looking at different, looking at population studies and seeing who has healthier gut floras and what is it predisposing our risk to, and how long does it take to change your gut flora. So population risks of Americans and Africans were done, and who do you think had a richer gut flora? Yeah, Africans, right? And then their diets were reversed, right? So the Americans would fed an African diet and the vice versa. And in 3 weeks, their gut signature changed. Now, we aren't always able to do this, right? Because I see patients and we check their microbiome and we say, okay, you need to be doing more fiber, you need to be doing more whole plants, and they can't. I'm like, well, I'm just going to pop a pill. Ain't going to work, right? So sometimes you need to heal their gut, and so that, you know, it's not leaky and they're able to absorb. But it's a path and a goal, right? You need to heal and enrich your gut, and that will lead to much better health. Let's talk about capsule endoscopy. We have this technology, should have been, I think it was probably invented by Israelis, but not that I'm biased, that you can swallow this little capsule, it'll go down your esophagus, go through your stomach, it can look at bleeding, it can look at early gastric cancers, and it'll go into the small bowel and will take really high quality pictures of your small bowel and detect early polyps, lesions, and the like. So I have a patient who had a liquid biopsy done and had a very high signature for colorectal cancer, and I'm running his whole bowel. And part of the running the small bowel of the whole bowel is looking at his small bowel, and it's going to be upper bowel and lower bowel, which is where we usually stop. But the small bowel neoplasms are notoriously very hard to find because small bowel is very pliable and it can hold a lot of crap, literally, right? It's distendable. So by the time that people start having issues and obstruction, the tumor is so big, especially in the small bowel, that, oh my God, it's too late, or the lymph nodes are involved and you need a major vac and chemo. So you can detect with this, available technology, if you're using it smartly and risk stratify people, early polyps, just like in the colon. Let's look at pancreatic cancer. It is projected that pancreatic cancer is going to outcompete colorectal cancer, which is currently number 2 killer, within the next 2 decades. It's going to be number 2 cause of death. And not just by a little bit. The incidence of pancreatic cancer projected to increase to 150% over the next 10 to 20 years. And what's the current standard of care?